Let's be real, neck pain is one of the top things patients come to us about behind the counter, right? So today, we're going to build a pharmacist's playbook for this. We'll give you a solid, evidence-based game plan to manage it confidently, from that first crucial conversation all the way to handling those tricky, persistent cases.
Okay, first things first, let's get on the same page about what whiplash actually means. It's not just about having a sore neck. It's really about the mechanism, that violent, super fast back and forth motion. Understanding that jolt of energy is key, because that's what can lead to all sorts of different injuries we need to be aware of.
So here's our game plan for today. We'll start with that critical patient assessment, then we'll walk through managing the acute and chronic phases. And we'll wrap it all up with a practical counseling cheat sheet you can literally start using on your next shift.
This is where we, as pharmacists, really shine. Before you even think about reaching for a product or recommending a single thing, our most important job is to screen the patient. This is our chance to act as that accessible, frontline healthcare provider. Okay, job number one, your absolute top priority is safety. We have to rule out the scary stuff first. That means we have to be detectives, looking for red flags, those signs and symptoms that tell us, whoa, this isn't just a simple neck strain, and that patient needs to see a doctor now. You should have this table burned into your brain. It's your essential triage checklist. So if a patient mentions they've been losing weight without trying, and they have a history of cancer, your brain needs to immediately connect those dots to a potential tumor. Or if they have a fever and a stiff neck, that screams possible infection. Knowing these red flags isn't just good practice, it's absolutely fundamental.
All right, so you've screened for the big, scary stuff and it's safe to proceed. What's next? The next step is to kind of mentally classify how severe the injury is. This is what's going to help guide your recommendations.
The standard tool we use for this is the Whiplash-Associated Disorders, or WAD, classification. Now, don't get bogged down by it. Most of the patients you'll see in the pharmacy are going to be WAD 1 or WAD 2. Pain, stiffness, maybe they can't turn their head all the way. The big differentiator, the one that means an immediate referral, is WAD 3. The second you hear about neurologic signs, numbness, tingling, weakness down the arm, that's a red flag in itself. WAD 4, of course, is a straight-up emergency.
And you've got to keep this timeline in your head too. It's so important because our strategies have to change over time. What works in that first acute phase is often the totally wrong approach when someone's pain becomes chronic. So in that initial acute phase, those first 4 weeks, our goals are pretty straightforward. We want to help reduce their distress, for sure. But the main goal is to help them get back to their normal life as quickly and safely as possible.
Okay, lean in for this one, because this might be the single most important non-drug counseling point you can make. The evidence is overwhelming. Active recovery is king. Patients are going to ask for a neck collar, they're going to think they need to lie in bed for a week, but we now know that can actually make things worse and delay healing. Your advice to keep moving gently is more powerful than any pill you could recommend.
Now, this next point is a huge clinical pearl, and honestly, it might go against what we've been taught for years. The evidence is pretty clear now for spinal pain, and that includes acute neck pain. Acetaminophen just doesn't work. It's not effective. And that's a really critical piece of info to share with patients who are probably reaching for it first. So if acetaminophen is out, what's in? Well, NSAIDs are the go-to, but our counseling is key, right? Use the lowest effective dose for the shortest possible time, and always, always take it with food. For muscle relaxants, the #1 counseling point is sedation. You have to tell them, this can make you drowsy, do not drive. Frame them as a short-term tool to help them move, not a long-term solution.
Okay, but what happens when the pain just lingers? When a month goes by and the patient's not getting better? This is where our thinking has to shift. We need to dig a little deeper to figure out what's stopping them from recovering. See, when pain sticks around, it's often about more than just the physical injury. After about 4 weeks with no real improvement, we need to start screening for what we call yellow flags. These are psychosocial factors that can actually predict a poor recovery. This is all about listening to the language your patient uses. Are they saying things like, "This pain is the worst thing ever, my life is over"? That's catastrophizing. Or, "I'm terrified to move my neck in case I damage it more." That's fear avoidance. These yellow flags, plus things like depression or anxiety, are huge predictors of pain becoming chronic. Just identifying them is a huge step. And look at this. This is so important. As time goes on, the evidence for our old standbys starts to fall apart.
While NSAIDs were a pretty good choice in that first month, their effectiveness really drops off when the pain becomes subacute. So continuing them long-term often just adds risk without much benefit.
So for these tougher, more persistent cases, the pharmacologic toolbox gets a bit bigger. You might start seeing things like tricyclic antidepressants, where you'll need to counsel on side effects like dry mouth and constipation, or GABA derivatives like gabapentin, where the big counseling points are sedation and dizziness, especially when they first start it. And of course, opioids should always be the absolute last resort for short-term use only.
Okay, let's pull all of this together. Let's make a super practical rapid-fire guide that you can take with you. This is your counseling cheat sheet for neck pain. This is it, your 4-step workflow. Screen, educate, advise, identify. Just run through that in your head every single time. Screen for safety, educate on movement, advise on what the meds can and can't do, and identify those yellow flags if things aren't getting better. This is where you can be a hero. Your job is to be the champion for active recovery. You're the one who can confidently debunk the myth that bed rest is the answer. Encouraging gentle movement and getting back to normal life is one of the most powerful things you can do for these patients. And on the medication side, let's keep it simple and clear. Acetaminophen, tell them straight up the evidence shows it's not effective for this. NSAIDs, shortest time possible, with food, and talk about the risks. Muscle relaxants, they're a short-term bridge to help with movement, not a cure, and please always warn about the sedation. So I'll leave you with this final thought. We're all experts at asking, what are your symptoms? But maybe the more powerful question is, what are you worried this pain will stop you from doing? That's the question that uncovers the yellow flags. And that, right there, is how we elevate our practice from just dispensing to truly guiding our patients toward recovery.